Good morning, ladies and gentlemen.
Good morning, sister.
Good morning,
You're all welcome
Good morning.
and Happy New Year.
Good morning.
Many happy returns, sister.
Thank you.
Many happy
Shall we just give them 5 minutes? They are coming in. Agreed?
Yes, sister.
Yes, sister.
Yes, sister.
Yes, sister.
Thank you very much. Okay, good morning.
Good
Good
morning.
I think we have a good number, so we can start. This morning, we are going to start a very important and interesting course, abnormal pregnancy. Abnormal pregnancy. As the word reveals, anything that is not normal is problematic. Anything that is not normal puts people on their toes. And the whole of last semester, we handled normal pregnancy. As long as we talked about normal pregnancy, we know that there is a likelihood of abnormality. And so this morning, we are here to discuss abnormal pregnancy. You need to know what it is. You need to know the signs so that when you see it manifest, you handle it immediately so that it may not be detrimental to our main focus, which is the fetus and the mother. Abnormal pregnancy is the study of conditions that have deviated from the normal. That's what we have here. And so it is important to identify such conditions. When you identify them, what do you do? Wow. When you identify them, you learn them. And when you learn them, you watch them. You learn those conditions. How do you learn something? You learn what it is. How do you handle it? And that is why we are here. So that we learn them, know how to manage them. So the conditions we have here, I don't know why abortion is okay. Abortion is at the top there because ectopic pregnancy results in abortion. Molar pregnancy could give you bleeding. And somebody would think, if it does, one would think it's abortion. And then implantation bleeding, depending on the severity, one could feel her pregnancy is threatened. We will have abortion on its own. Now, incidental bleeding comprises of, remember on the first slide we had talked about the table of content, and this is the table of content you are looking at. Incidental bleeding comprises of the polyps, cervical erosion, carcinoma of the cervix, trauma. Hypertensive disorders in pregnancy are not actually supposed to be here. The disorders of pregnancy due to hypertensive condition is not supposed to be here. It will come in medical conditions in pregnancy. Also, in this course, we will talk about bleeding in late pregnancy, which has to do with placenta previa and abruptio placenta. Then multiple pregnancy. And then we have medical conditions. Hypertensive disorders come under medical conditions, actually. Then we also have implantation. Sule, are we all right? Are we okay? Should we continue or we should wait?
Yes, sister, let's continue. I'm sorry.
We also will discuss implantation bleeding, which we had said that one could mistake it for bleeding for abortion or threatened abortion. Then we come to bleeding in early pregnancy proper. So what is implantation bleeding? We all know that implantation bleeding is a small amount of light spotting or real bleeding per vaginum. It occurs mainly about the 10 to 14 day after fertilization. It is common, but it is not a sign of any problem. Implantation bleeding is thought to occur when the fertilized ovum attaches itself to the endometrial lining. Ordinarily, people do not really worry about it. They see it. If it comes light, and the next day you don't see it again, for those who know, it's okay. For those who do not know and are careful enough, they may begin to wonder what has happened. For those who do not know and are not very careful, just ignore it and off they go. Until they find out that for the next 3 months, they have not bled. They have not menstruated. And if this category of people are those that are married, they are not bothered. But if the category of these people are those that are not married and are not ready for pregnancy, they become concerned. They become worried. The same thing happens to the careless ones who just ignore and go. Okay, that's the careless ones I have talked. The careful ones may ask, they may want to seek knowledge. This month, my menstruation it was just a slight spot. Or it came, but did not flow as it used to. What could be the problem? For those that are married, they could be happy to know that they're expecting a baby. For those that are not married, on getting information, may receive the news with joy or with sadness. Whatever the case, that is not so much our concern for now. Our concern for today is to know what implantation bleeding is. Signs of implantation bleeding. The color is light pink or brown. The strength of flow is usually spotting, which may occur once or at least a few hours or even up to 3 days. There are some people who use sanitary pads. I have a colleague. She is a nurse. In fact, 2 of them. One, my sister-in-law. One, a friend. Their implantation bleeding, even as nurses, came early. Came heavy. My friend and colleague did not even know until it was 6 months. No, it wasn't 6 months. It was about, she kept bleeding, and then one morning she fainted. She just collapsed because she was busy doing what she normally does. So she was taken to the hospital. It was in the hospital that it was diagnosed that she was pregnant and has gone a couple of months. My sister-in-law, I think hers was up to 6 months. She didn't have any problem. That's the first pregnancy now. She didn't have any challenge. She only observed that she was becoming busty. Her bust was increasing rapidly. And then she was putting on weight. Then out of that, she just decided, okay, even that particular day she went to consult, she was with a sanitary towel. And the news came. that she was 6 months gone. So it does happen. I'm sure as I am talking, among you people, you have those experiences. It could be personal experience. It could even be from your patients. One may notice some pink or brown discharge when she wipes or on her underwear, but she will not need a full sanitary pad. That's what is supposed to be there. She may not need a full sanitary pad. The griping pain may be slight and short-lived. When you look at the third bullet is talking about the ideal. The ideal. Does somebody have experience like what I am saying? Implantation bleeding going beyond what it should be? Do you hear me at all?
Yes, sister.
Yes, sister.
Yes, sister.
Have you forgotten that in my class, I like it interactive?
No, sister.
Yes, sister.
So I asked if you have any such experience. If you don't have, just say no and we continue.
No, sister.
No, sister.
No, sister.
No, sister.
Any vaginal bleeding before the 20th week of gestation is defined as bleeding in early pregnancy. Somebody is pregnant and she comes to you. I don't know what you were taught. During our time, we were told before the 27th week, or 28th week rather, because then it was taught that viability was at the 28th week. But today, many people are saying viability of the fetus is about the 20th week. So that's why we have it. What period were you taught that a fetus is viable?
28 weeks.
28 weeks.
28 weeks. 28 weeks. I have to quickly
Yes,
put
sister.
that because people will raise questions. Evelyn, are you okay? Are you saying something? Is what you are saying of our interest. So you look at the diagram on the right. You can see the endometrial lining there. Then you see...
Sister, please, I said 28 weeks.
Your network, it was breaking. Sorry. Then you look there, that is the placenta. Can you see my cursor?
Yes.
Yes, sister.
Yes, sister.
And
Yes,
that
sister.
is the umbilical cord there. So what you have all here is bleeding. That's the bleeding, that's the hemorrhage. While inside here, is the fetus. And then the bleeding here is visible because the person is bleeding per vaginum. Now, you look at it. Causes of bleeding in early pregnancy. It could be abortion. It could be ectopic. It could be high datidiform wool. And what you have seen there are possible sides of ectopic pregnancy. Ectopic pregnancy could be seen in the fimbriated area, in the ampulla of the fallopian tube now, or you could have it in the isthmus. The ampulla is the widest part. The fimbriated area is the finger-like structure. And then the isthmus is the most narrow part. Occasionally, you may have it in the cornua. And then around the ovary there, you can have it there. Instead of going into coming out and then moving through the fimbriated edge inside, the fertilized ovum just remains there. You could have it by the side of the cervix, again in the cornua there, that is between the tube itself and then the cavity. It could be in the peritoneal cavity. It could be in the peritoneal cavity. Or it could lie between the ovum, what do they call that one now? Ovary and the tube. Now, when we talk about bleeding in early pregnancy, you have bleeding that is related to the pregnant state. Abortion is directly related to the pregnant state. Ectopic pregnancy is related to the pregnant state. Molar pregnancy is related to the pregnant state. And then you have, of course, the implantation bleeding. Now, you also have bleeding that is associated with the pregnant state, but is not related, like the cervical erosions, ruptured varicose veins. The varicose veins are because of the pregnancy. And so when they rupture, at that time, they are associated with that. Cervical erosion. You could see it somewhere else called cervical ectropion. It's the same thing. So you look at the cervix, you see the vaginal wall. The cervix is brought out. Now, inside the cervix, you have the ectropion there. How do you view it? You use a speculum to view the cervix, to bring it, to open up and bring it out. When I say open, not opening with a knife now. So you are viewing it through the speculum. What we are looking at now is the cervical polyps. This is the sagittal view of the polyps. You can see the polyps hanging there with a little thread, very tiny thread. And looking at this, it must have been well magnified. The picture must have been well magnified. This one here is malignancy. You can see how it looks. Malignancy, associated also in pregnancy. Now, the pathology. What happens is that there is bleeding into the decidua basalis. And we know that the lining of the endometrium that is at the base is called the basalis, decidua basalis. So when there is bleeding from anywhere into the decidua basalis, it's a kind of scrapes the lining, the decidual lining. And when that happens, you find out that there is no more blood supply. So it becomes necrotic. The tissues, the adjacent tissues to the bleeding site become necrotic. Once they are necrotic, there is detachment of the conceptus. The detachment happens around that area. And this stimulates the uterus to contract, resulting in expulsion of the conceptus. The next thing we want to talk about is ectopic pregnancy. But sorry, I crossed, I didn't ask. Do you have questions to ask?
Sister,
Yeah?
sister, please. Good morning. My name is Zuerat. Sister, please. What is the I don't really understand the difference between the related courses and the associated courses. Can you please explain further for me?
Okay. Thank you. We go back to that. When a course is related, that cause is coming because of the pregnancy. For instance, we talked about, have we moved? We talked about, okay, this is the right place to understand. Whether it is ectopic, when it is an abortion, there is bleeding that gets into the decidua. And once the decidua basilis is affected, degeneration of the adjacent tissues occur. In other words, this is directly coming from the pregnancy. That is why we say it's related to the pregnancy. When it is ectopic pregnancy, it is the pregnancy that is being aborted because the embedment was in a wrong site. And the same thing, when it is a molar pregnancy, it started like pregnancy and then it degenerated to that level. But when it is associated with pregnancy, like the malignancy here, what is affected is the cervix because of malignancy, not because of the pregnancy. The bleeding is coming from the cervix because of the malignancy, not because of the pregnancy. Hello.
Hi.
Hello, sister.
Hi.
Thank you.
Hi.
Do you
Hi.
understand now, Abubakar?
Yes, sister, I understand. Thank you so much.
So, like the varicose veins. The varicose veins could be in the leg, they could be in the vulva. They are not coming from the pregnant state, but because of the varicose veins. All right. God bless you. Any other question, please? Yes?
Adia.
Any other question?
Yes, sister.
Go ahead.
I'm your friend, Hadia.
Please, Amarin, Amano. Please, I want to find out whether does myoma cause bleeding in pregnancy?
What is myoma?
Fibroid. Uterine fibroid.
Where is it?
Being in the endometrium or at the fundus area.
Fine. Most times, that condition interferes with pregnancy. It does not allow pregnancy to take place if the myoma is in the endometrial lining. But if it is outside the cavity, pregnancy can take place. For that one now, where myoma gets to a point of bleeding, you find out that pregnancy hardly comes up because the person will be more concerned with the condition. But if it is in the cavity, it could interfere with the growth of the pregnancy. And so it could threaten the pregnancy or even cause abortion, complete abortion. So if it is outside, on the uterus, outside, most times, depending on the condition, the gynecologist may schedule a laparotomy remove the myoma and allow the pregnancy to go on. I have seen it before. Or manage it until delivery. Do a cesarean section and remove it. Remove the live baby and remove that. But if it is in the lining, endometrial lining, I don't know. Most times it interferes. But talking about fibroid generally, they get to a point where they cause a lot of bleeding. Hello.
Hi. Thank
Hi.
you.
Hi, sister.
Hi, sister.
Hi.
Are you okay? Do we continue? Is there anything you still want to know?
No, sister, thank you.
Any other question, please? Do we continue?
Yes, sister, please, we can continue.
Thank you very much. Why are you here? Please move. Eh. Now, ectopic pregnancy. Ectopic pregnancy is one in which fertilized ovum is implanted and develops outside the normal endometrial cavity. We talked about it in the last slide. We identified about 10 sites. But what I failed to mention is that the ones that are planted in the peritoneal cavity go to 10. Some. Don't ask me why. I don't know. I mean, don't ask me how. I do not know. But some of them go to 10. But the ones in the tube cannot go to 10 because the cavity of the tube is not wide enough. For the peritoneal cavity, I do not know where the placenta embeds. It's only God that knows. So you can see this here. This must have been well magnified. You all know that the fallopian tube is quite small. You see the uterus there. Here it is. The bowels are here. You see the right fallopian tube is the one that is affected. And inside the fallopian tube, you can see blood clots. And we are told that this pregnancy is about 5 weeks. It must have been in the ampulla because the ampulla is wider. That is why it can last till 5 weeks. And this explains why they are always in shock, why they faint. Because they are bleeding severely internally. This explains why the ultimate treatment is cesarean section. Incidence. It is increased during PID, pelvic inflammatory disease, or during the use of IUCD. It is increased during tubal surgeries and also during assisted reproductive technique. And we are told that it ranges from 1 in 25 to 1 in 250. So which one is high? 1 in 25 or 1 in 250?
One in 25.
1 in 25. 1 in 25.
1 in 25 is high, very high, very high, very high. The average range is 1 in 100. That is in all normal pregnancies. Late marriages and late childbearing is 2%. ART is 5%. And then we are told that recurrent rate is 25% after the first. And 15% after the first and 25% after 2 ectopics. I will shout fire. There are cases where, depending on the condition, the person might have ectopic on both tubes. So you have
Apungu le buru soto le buru ona ze nyebo kayo soto po. Opi amako. Na asop. Ma asop be sibiti ni la o mapan.
Sister Priscilla, please.
Sorry, the network. I'm trying to call ICT. I'm actually in my office. Let me call and see if it happened there. Okay, if it didn't happen there, if it happens again, I will have to transfer down there. So these are the different, okay, we were here.
The AT number you are trying to reach is busy. To send a
Now, what is the etiology of ectopic pregnancy? Ectopic pregnancy, we have tubal factors, we have zygote abnormalities, we have ovarian factors, and I don't know why this thing is closing my view. To go down, it has refused. Please, somebody read what is there. Like, okay, you have the oral contraceptives and then endometritis. So when we talk about the tubal factors, you know, salpingitis, previous tubal surgeries are problems. Under zygote abnormalities, chromosomal abnormalities, this for this one, I believe nature has a way of helping the woman. Where there is chromosomal abnormality, instead of this woman suffering in pregnancy and suffering again to take care of the child, of such a child, nature just flushes it out. And then you have the ovarian factors. And then sometimes contraceptives can cause these problems. Contraceptives. And then endometritis. Probably that woman has been using IUD or something. Either intrauterine device that could cause that, or if she had intrauterine death and that fetus decomposed in utero before it was released, it could cause endometritis. Please, do you have any question to ask here? Are we in class?
Yes, sister, we are here.
Yes, sister.
Yes,
Yes.
Okay. Do you have a question to ask
We
them?
are here.
When is this class actually ending?
10:15.
11:15.
11:15.
11:15.
Yes, sister.
Okay. And the next one will start at 11:45. Okay.
Yes.
All right. Yes. You don't have a question? Do we move?
Yes, please.
Yes, sister.
Okay. Now, the fate of tubal pregnancy. You have the tubal mole, you have tubal abortion. Can somebody help me read, please?
Yes, sister.
Yes, sister.
Okay.
Tubal mole.
Please,
Three. Abutere.
Who is reading? Abubakar, read.
Tubal mole.
Oh,
The gestational sac is surrounded by a blood clot and retained in the tube. This may remain for long period in the tube and form so-called chronic ectopic pregnancy, or they may be gradually absorbed, that's involution. Then 2, tubal abortion. This occurs more if ovum had been implanted in the ampullary portion of the tube. Separation of the gestational sac is followed by its expulsion into the peritoneal cavity through the tubal ostium. Rarely, reimplantation of the conceptus occurs in another abdominal structure, leads to secondary abdominal pregnancy.
so you see, when they say tubal fit, that is what is caused by mainly by the tube. In the first one, the gestational sac that is surrounded by any blood clot could remain there, causing chronic ectopic pregnancy. Or it could even be gradually absorbed. And when such an involution takes place, there may be a problem. If it occurs in the ampulla again, it will not grow beyond a particular period. That's the tubal fit. Then the third one, go ahead.
Tubal rupture. More common if implantation occurs in the narrower portion of the tube, which is the isthmus. Rupture may occur in the anti-mesenteric border of the tube. Usually profuse bleeding occurs. Intraperitoneal hemorrhage. If rupture occurs in the mesenteric border of the tube, blood ligament hematoma will occur.
So this is the ampullary,
Tubal rupture.
That is it there. You can see this one obviously is at the fimbriated end. This one is likely to be, the prints are so small we cannot read. Can anybody read them so that we know exactly where they are? This one is the fimbria, the fimbriated end. This could be in the ampulla. The question you want to ask is, will any of these ones in the tube go to term? No, even though the ampulla or the ampullary region is large enough, but it will not, it cannot take it to 9 months. No, it can't.
That's
Can somebody read?
peritoneal hemorrhage.
Who has such good eyes?
Sister, you can enlarge it from your end, or we are trying to enlarge by
I tried to enlarge it, it did not go.
Okay.
I have tried to enlarge it, it did not go.
I read.
This one here says conception at the 8th week. Conception at 8 weeks. But I am more interested in the area. What area is this? Can somebody read this one? This conception, I don't know how many weeks here, I can't see it.
Hello, sister.
Yes.
Fate of tubal pregnancy.
What? Is it this one you're reading?
Yes, please.
Please, is it where the
Please,
cursor is that you want us to read or where?
where the first case are.
What I want us to read, you see, like
Where
this
is
one
the
here,
first?
it talks about 12 weeks. But where is it? Is it in the ampulla? Is it in the fimbria? This one is clear. The picture is clear. It is at the fimbria, the fimbriated end. But this one, where is it? Is it in the ampullary area? Like this one, where is it? Here, they just said 12 weeks, ectopic pregnancy. There is labeling here. I want to know what region that is. That's why I am asking. But let's continue.
Sister, please, it's in the ampulla.
Sorry?
It is in the ampulla.
Which one? Okay, this one, this
The
label.
one? Yes, yes.
Ah. Oh, well, it's okay. Because I know it is the ampulla that might go to 12 weeks. The ampulla might take to 12 weeks and nothing more. Okay. Presentation. Early symptoms are either absent or subtle. Clinical presentation of ectopic pregnancy occurs at a mean of 7.2 weeks after the last normal menstrual period. So you see that around the 7 weeks, from 5 weeks, they begin to manifest. She may begin to have, of course, there is amenorrhea. There is amenorrhea. The signs of ectopic are not always manifest suddenly. The most common presenting symptoms that are suggestive of ectopic pregnancy are what? Can you know them? Can you know them? Here they are. It is a trio of 3 A's: amenorrhea, abdominal pain, and abnormal vaginal bleeding. Amenorrhea, abdominal pain, and abnormal vaginal bleeding. But when you use this trio, or the triad, sorry, if you use this triad, you can be confused because you begin to ask yourself, what is the abnormal vaginal bleeding? You don't need to confuse yourself. Any pregnant woman who bleeds vaginally during pregnancy, that bleeding is abnormal. Hello? That bleeding is abnormal. Because bleeding in itself has nothing to do during pregnancy. True or false?
True.
True.
True, sister.
The patient looks quiet and conscious, but perspires and looks blanched that is looking pale, pallor is there. There are features of shock. The abdomen feels tense, tepid and tender. No mass is usually felt. You see the problem. But most times, as the person is being palpated, there could be a shifting. You as you're palpating, as the medical doctor, the obstetrician is palpating, there is a kind of dullness that is not present. You want to feel something here, it shifts. Not, I don't mean that is not present, that is not permanent, that is not fixed. You want to, you feel like there is something dull here and you want to confirm whether it is a mass, it shifts. Please, patience, help me read what is under that shadow. Is Patience in class? She wanted to read before. Where is she?
Madam, is it Priscilla or Patience?
I don't know. Somebody raised their hand here. You are asking me, you are Techno here. I don't call Techno to talk. A Patience raised their hand to read before. She's the one I'm calling out to read.
Yeah, okay.
If she's not there, Esther, another Esther to raise hand, read. Abubakar read before. Or if they are not ready, who is ready to read?
Madam, please, which one?
Esther, go ahead.
Signs. The patient looks quiet and conscious, perspires and looks bleached. Pallor. Features of shock. Abdomen feels tense, tumid, and tender. No mass is usually felt. Shifting dullness present. Pelvic examination reveals bleached white vaginal mucosa. Uterus seen normal in size or slightly bulky. Extreme tenderness on fornix palpation or on movement of the cervix. No mass is usually felt through the fornix. The uterus floats as if in water.
It floats as if in water. That is because it is on fluid. There is bleeding there. So those are the signs. And you can never miss them. Go ahead.
Unruptured tubal ectopic pregnancy. Symptoms. Presence of delayed period or spotting with features suggestive of pregnancy. Uneasiness on one side of the flank, which is continuous or at times cloaky in nature.
Colicky.
Thank you, madam.
Colicky means painful. It's painful in nature. Continues. Or continue.
Signs. Uterus is usually soft. Epicellal small. Well circumscribed tender mass may be felt through one fornix separated from the uterus. Chronic or old ectopic. Symptoms. amenorrhea, lower abdominal pain, vaginal bleeding. Signs: the patient looks ill, pallor, pulse persistently high even during rest. Features of shock: temperature may be slightly elevated.
The temperature will be raised. And then the patient is continue.
On abdominal examination, tenderness and muscles guard on the lower abdomen, especially on the affected side is striking.
Okay. Sorry, let me speak directly. Ben, please. Good morning. It's likely I will come over there. I'm in the office and the network here is not steady. Like you saw, it has gone off before. So if it happens again, please, I'll come over up there. Thank you. Yes. So the tenderness is something that you can never rule out. It can never be overemphasized. The abdomen is very tender. The mass in the lower abdomen may be irregular, but it has to be tender. Then you have the bluish dark discoloration, which is called the Collins sign. When this is found, it suggests that there is intraperitoneal bleeding. This Collins sign may not be obvious in a dark-colored person. But if the person is very light, it will be quite obvious. Diagnosis. Go ahead.
Diagnosis of ectopic pregnancy. 1. Pregnancy test. Positive, that's 82.5%. Hematocrit. White blood cells count. A negative test does not rule out an ectopic gestation.
What does that mean? That you did a pregnancy test and it gave you negative. The test came out negative, does not rule out ectopic pregnancy. The woman could be pregnant, but it is ectopic. Continue. Acute. Somebody has a system. When the person puts it on, it causes this. It enlarges my voice. I don't know who has it. Yes, continue, Esther.
Subacute chronic ectopic. Blood examination. Choledosynthesis. Estimation of beta HCG. Sonography. Color Doppler sonography. Combination of quantitative beta HCG values and sonography laparoscopy. Dilation and curettage. Serum.
Okay, continue.
Serum progesterone. Then laparotomy.
Who can tell me a test that is a telltale? Once that test is done, there's no argument. There is ectopic pregnancy. Who can mention it?
Madam, please, HCG.
What?
They do HCG tests to know I think they have a particular number for the HCG. So if it is going high, when you do it and it is going high, meaning there's pregnancy. But if it is decreasing, meaning
Yes,
there's no pregnancy.
you're correct. HCG tests generally, when we talk about pregnancy. But you also had somewhere there which said that a negative test does not rule out. In other words, there are conditions where the HCG will not even be identified. But the main diagnostic test that is done, that is telltale, once it is done, there's no argument, it's abdominal tap. I don't know whether your doctors here do not do it. It's abdominal tap. Just take an empty syringe and a needle, pierce it into the lower abdomen. As you draw, you will draw out blood. Once blood enters the syringe, no more argument. In other words, there is bleeding. There is bleeding. Your doctors do not do that?
I've not seen it being done before, but what we do know of is mostly they are requested to go for a scan. So the scan is able to identify that there's ectopic and then there's fluid showed up in the abdomen.
Yes, the scan, yes, and the tap. Okay. Go ahead.
Please, I wanted to ask a question.
Go ahead, yeah.
The tapping of the stomach, as you are saying, is it when the ectopic have been ruptured or when it is not yet ruptured? So when you mean
It's
to put
when
the
the
empty
woman
syringe.
comes. The woman has come, seen all those signs. So you want to confirm.
Okay, thank you.
It runs pari passu with the what is that test? It is either you do the tap or you send the patient for X-ray. I've just forgotten the name. Mentioned it now. Mention it now.
Please, is it a history?
Ultrasound.
Sorry, ultrasound.
You say, is it what?
The scan that you are talking about. Sorry.
Thank you. Yes, Cecilia.
Please, Ma, with the tapping you spoke about, what I have seen the doctors at my facility do is that they passes the needle through the cervix. And when they draw blood, then they tend to diagnose that it's a ruptured ectopic pregnancy, because when it's ruptured, the woman will bleed into the pouch of Douglas, and when they passes the needle through the cervix, they are able to draw blood from it to confirm that it is an ectopic, but it's ruptured at that time.
Okay, that's another way. Way. So what I'm trying to say is the main diagnosis is the scan, the abdominal tap, or that what you have just said down. Yes, the cervical tap. All that, the taps are when there is rupture. All right. The management.
Conservative management, either medical or surgical. Medical management. The drugs commonly used for synthesis are methotrexate, potassium chloride, prostaglandin, or actinomycin. Conservative surgery. Linear.
I want to ask, What do you use commonly? Do you use the medical management or the surgical? I mean, in the service area. What management is used for ectopic, ruptured ectopic here?
Yes, mostly we use the surgical.
Mostly we use the surgical, yeah. We use the surgical because it needs repair. The inside needs repair. So if you use the medical, what will happen to the tear? But you know, the white people have the way they do their management. I mean, what will happen? Yes, the tear, the ruptured end. Continue.
Linear, that's conservative surgery. Linear salpingostomy. It has repeated them. Segmental resection. Fimbrial expression. Then salpingectomy.
Those are the different repairs that I was saying. I said, what happens to the tear? So those are the different ways that I used to do the repair. When you open into the fallopian tube linearly, you have to close it up.
Other sites for tubal pregnancy. Peritoneal cavity. Cervical pregnancy.
And this is the ectopic pregnancy we are talking about. Complications.
Complications. About 1 in 1,000 ectopic pregnancies result in maternal death. Untreated or mistreated ruptured ectopic tubal pregnancy, that's 8 to 12% of all maternal deaths. The majority of these deaths are preventable.
What makes them preventable? Marvelous, what's your problem? Okay, Marvelous, tell us, what makes these deaths preventable? Why do we say majority of these deaths are preventable?
Please, madam. Please, it will.
I'm asking Marvelous. Let Marvelous answer me. Because she decided to disrupt the class. Okay, Abubakar, let's hear you. Abubakar Sadiq.
The deaths are preventable only when we are able to detect early and then manage properly.
Yes. Yes. When these are detected and well managed, you prevent death. A woman comes to the facility, she walks in there, she is conscious, and she is attended to immediately. Nothing will kill her. But when she doesn't come to the clinic, she does not even know what is happening, or she comes late, anything can happen.
Sister, please, can I share an experience with the
Yeah, go ahead.
ectopic? Yes. And sometimes too, the death are as a result of some of the teenagers or the unprepared women. When they see that they've missed their menses, they do the test and it's positive. They try to get rid of it by themselves instead of visiting the facility. I once, during one of my services, I came into contact with a certain lady who has come to a funeral somewhere, realized that she was pregnant, not knowing where the pregnancy is situated because she did the test and then it was positive. She tried to abort it by taking the medication. Lo and behold, the thing was an ectopic pregnancy, and then it's ruptured because she was trying to get rid of it. Eventually, we lost her because the time she reported, it was too late. She has started bleeding into the skin. You see, the skin has become bruises all over. And then when we have to get the anesthetist, we were not getting the anesthetist for the procedure to be carried out. GIC setting, all possible ways to manage the case to Rita, and then we lost her. So sometimes too, it's as a result of the people getting rid of the pregnancy by their own means. Thank you.
It is well. Thank you for that contribution. Thank you very much. Okay, Esther, continue. Who was reading?
Madam, please, me.
Continue.
Intestinal damage, chronic salpingitis, infertility or sterility. Intestinal obstruction may develop after hemoperitoneum and peritonitis.
So these are the things that damage the tube completely because of ectopic pregnancy. The cause of ectopic pregnancy. The salpingitis may become chronic. She might become infertile. That could render her completely sterile. You heard the contribution of comfort. When they don't come to the clinic, when they are not well managed, you have these challenges. It could even result in intestinal obstruction. What could cause intestinal obstruction? When there is severe bleeding in the peritoneum. That bleeding in the peritoneum could result in peritonitis. Thank you.
Welcome.
Who else is ready to help in reading?
Gestational trophoblast diseases.
Esther, you're not clear.
If someone is willing to help.
Oh, okay, I read. Gestational trophoblastic
Tegno.
disease.
Who is Tegno? Tegno is not a
Madam,
human being.
Okay, I read. I'm Presla. Gestational trophoblastic.
What's your name?
I'm Presla Uni.
Go ahead.
Gestational trophoblastic disease. It is a term formally applied to a spectrum of interrelated diseases
originating from the placental trophoblast.
So you see that the trophoblastic gestational disease or gestational trophoblastic disease, GTD, are diseases, there are many, originated from the placental area that truncate pregnancy. Go ahead. Who was reading?
Madam, I'm the one. Classification. The conventional histological classification includes 1. Hydatiform mold, into bracket complete or partial. 2. Inversion mold. 3. Choriocarcinoma. 4. Placental side trophoblastic tumor.
Placental side trophoblastic tumor. The main problem in this thing is that they all come from the trophoblasts of the placenta. Go on. Modified World Health Organization classification on GTD. That is, the World Health Organization has modified these conditions. So go ahead.
Hydatiform mold.
Hydatiform.
Hydatidiform mold. Complete partial inversion mold. Placental side trophoblastic tumor. Choriocarcinoma. The last one. Non-metastatic disease and metastatic disease.
Be patient in reading your words. You say your name is what?
Not clear.
Madam,
I'm not getting the words clear at my end.
Then some other person should help us. But what I want us to understand is that we had these lists. You have the hydatidiform mold, which is complete or partial. You have the invasive mold. You have, I don't know, I can't see that word. That's why I always ask you to help. What word is it? Choriocarcinoma. Then you have the placental site trophoblastic tumor. That is 4. But we are told here that World Health Organization has modified it. So, hydatidiform mold is now complete, partial. That is, the invasive mold has been added to the hydatidiform mold. Then you have the placental site trophoblastic tumor, as we have, and then the choriocarcinoma now is put into 2. You have the non-metastatic and the metastatic. That is the classification of the World Health Organization. Then you have the low risk, that the low risk has a good prognosis. Then the disease is present in less than 4 months. That's the low risk, less than 4 months duration. Then initial serum, the HCG level is less than 4,000. The metastasis limited to the lungs and the vagina. Non-prior chemotherapy, or rather no prior chemotherapy, no preceding term delivery. And then you have the high risk, which is number 2. Again, I will have a challenge there because
Let me
the
help
bullet
you.
is closed.
Let
So
me
can
help you.
somebody read the high risk for me?
Yeah, long duration of diseases greater than
Okay.
4 months.
Mm-hmm.
Then we have initial serum ACG greater than 40,000.
Okay.
Brain or liver metastasis. Failure of prior chemotherapy. Following term pregnancy.
So you find out that these are classified again into the high and the low. The high is poor prognosis, while the low is good
Hurry up and join.
prognosis.
Hurry up. There's another motor
Sophia,
coming.
Sophia, mute
Hello, sister.
yourself. You know, these
Hello,
people who
sister.
just shout, there are people who just come in. You come in, you've not finished your business there, and then you put on the Zoom. Complications.
Hello, sister.
Yeah.
Is a concern on the high and low risk.
Yeah.
Are they talking under the carcinoma, where we have the non-metastatic and the metastatic? Either the low is going for the non-metastatic and the
Yeah.
high is going for the metastatic disease.
Yes.
Okay,
That is
thank
what it
you.
is. Thank you very
Okay.
much. Then you have the complications. The complications. We are told that about 1 in 1,000 ectopic pregnancies results in maternal death. Untreated or mistreated ruptured ectopic tubal pregnancies, that is 8 to 12%, all they result in maternal death. The majority of these deaths are again preventable. You see, what troubles me most is when death is preventable. Because when we talk about ectopic pregnancy, as dangerous as, when we talk about gestational trophoblastic disease, as dangerous as it is, if it is identified early and treated well, the person can survive. That person can survive. Damage to the tubal or to the tubes, tubal damage. Again, you have chronic salpingitis, you have infertility or sterility. There is intestinal obstruction, which results again from bleeding in the peritoneum and can give rise to peritonitis. You see, each time I talk about deaths that are presentable, I get emotional. It's like in general nursing, most times when doctors come out of the theater having performed particularly amputation, most doctors get very emotional. They get very, very emotional, very sad. Just like hysterectomy. When you are on the service area and you find out that A young lady who has not had her children or all her children undergoes hysterectomy. Is very painful. That's the same thing with preventable deaths. Okay. That is hydatidiform mole. You look at the granules looking like jollof rice. Look at it there. That's what you are looking at is not a bowl with soft jollof rice. It is a uterine cavity. Hydatidiform mole is an abnormal condition of the placenta where there are partly degenerated and partly proliferated changes in the young chorionic villi. The problem is the placenta. You have degenerative changes. What causes the degenerative change? Nobody knows. You have types of hydatidiform mole, can be complete or incomplete. Here again, I will need an assistant. Is there anybody in this class called Mabel?
Yes, sister.
So Mabel, read.
Features of partial and complete hydatidiform moles. So we have the features. And we have karyotype. Most commonly 69 3x or 2xy. That's the partial. Then with the complete, we have most commonly 46 xs or xy.
What do you mean by XX or XSY or XS or XY?
Since I think they are talking about the chromosomes.
Thank you very much. Continue.
Pathology. Fetus. We have amnion, fetal RBC, villus edema. Then with the partial, often present. So fetus often present. Then incomplete is absent. Amnion and fetal RBC are usually present in partial mole and absent in complete mole. Villus edema is variable or focal under the partial. Then in the complete is diffuse. Trophoblastic proliferation in the partial is focal or slight moderate. Then with the complete is diffuse or slight severe. Clinical presentation. Diagnosis. In partial is missed abortion. Then with the complete is molar gestation. Uterine size, small for dates, under partial. Then 50% large for dates, under the complete mole. Then we have thicker lutein cysts. It's rare under the partial mole and 25 to 30% under the complete mole. The medical complications is rare under partial mole, 10 to 25% for complete mole. Then post-molar CTN is 2.5 to 7.5% under the partial, and then 6.8 to 20% for the complete mole. Sister, that's all.
Thank you very much. So we have been given the features for the partial hydatidiform mole or the complete hydatidiform mole. Those are the features. Go ahead.
Okay, so gestational age for complete is 8 to 16 weeks. Partial is 10 to 22 weeks. Uterine size, they've not written anything there. Okay, uterine size, large for gestational age, under complete is 33%, partial is 10%. Then small for gestational age is equally 33% for complete and 65% for partial. Diagnosis by ultrasonography, most common in complete and then is rare in partial. Thicker lutein cyst, 25 to 35% under the complete and is rare for partial. Human chorionic gonadotrophin, above 50,000 for complete and less than 50,000 for partial. The malignant potential, 15 to 25% for complete and less than 5% for partial. Metastatic disease, less than 5% in the complete and less than 1% in partial.
Thank you. Then the complete mole.
Gross findings include massively large edematous villi that give the classic grape-like appearance to the placenta and lack embryonic tissue.
So you look at it there. It is large. It is edematous. And what are we talking about? We're talking about the placenta, the villi in the placenta. Continue.
Pathologic features include hydropic swelling in the majority of villi, accompanied by a variable degree of trophoblastic proliferation.
This is complete hydatidiform mole. The snowstorm appearance. And we are told that it is created by the multiple placental vesicles.
Clinical features: vaginal bleeding, varying degrees of lower abdominal pain, constitutional symptoms, expulsion of grape-like vesicles per vaginum is diagnostic of vesicular mole. Then the last one is history of quickening is absent.
There's no quickening because there is no fetus.
Signs: features suggestive of early months of pregnancy are evident. The patient looks ill. Pallor is present. Features of preeclampsia, hypertension, edema or proteinuria. Per abdomen, the size of the uterus is more than the expected period of amenorrhea. The feel of the uterus is firm, elastic. Fetal parts are not felt. Absence of fetal heart sound. Vaginal examination. Internal ballotment cannot be elicited. Unilateral or bilateral enlargement, that is thicker lutein cyst of the ovary. Findings of the vesicle in the vaginal discharge.
That's it. You know already that she passes vesicles. So there's no how you will not find the vesicles in vaginal discharge. They cannot be ballotment because there's no fluid. There's no amniotic fluid. There's no fetus. What is there is hard.
Invasive mole. Invasive mole is the most common sequela of hydatidiform mole, representing 70 to 90% of cases of persistent GTD. The disorder occurs when the hydropic chorionic villi are present within the myometrium. Its vascular spaces or at distant sites. I think it's at vascular spaces or at distant sites. This lesion has been known as chorioadenoma, destruens penetrating mole, malignant mole, and molar.
Chorioadenoma destruens.
Okay, chorioadenoma destruens, penetrating mole, malignant mole, and molar destruens. Up to 20% of invasive moles metastasize to extrauterine pelvic and distant sites. Example, lungs, vaginal, vulva, or broad ligaments.
Mercy, Lord. That is ectopic pregnancy we are still talking about. And this is the hydatidiform mole, the snowstorm appearance. So you look at the ectopic pregnancy, you see how the film looks like. And then the hydatidiform mole. See also how the film looks like. So we have been actually talking about bleeding in early pregnancy. We have discussed what it is and what it is made up of. We talked about the lesions or the conditions that are related to the pregnancy and the ones that are associated with pregnancy. So if you look at hydatidiform mole, it is related to pregnancy because it is talking about it stems from the placenta, from the villi. That is where it comes from. Do you have questions to ask? Where there are no questions, we call it a day. We meet again on Saturday. Do you have questions to ask? Hello.
Hi.
Bye.
Thank you for coming, and goodbye.
Goodbye, sister. Thank you.
Bye.
Bye, sister. Have a beautiful day.
Bye.